And we prepare some questions for Sheila about this recommendation. The first one is about the transition policy. In Taiwan, many care home managers advocate that this institute or institution can only care for residents in a chronic but stable condition. Once the residents are prognosed they are at end of life or enters the dying phase, such cases should be transferred to a hospital or hospice for better care. In the UK, there is the best developed palliative care network in the world. What is the consensus on this transition policy for care home residents at the end of life in the UK?
Well, thank you. That's a very good question to start with. And indeed, that used to be the policy in the UK. But now what we're trying to do is enable people to stay in the home that they're in, whether that's a home, a domestic home, or whether it's a long-term care facility, a care home, we tend to call them in the UK. Because they live there. So for a proportion of older people, they live there. And so what we're trying to do is enable people to continue to stay there. So the policy is not to transfer people to hospital unless there is a pressing medical need that they're likely to benefit from. So if they need emergency care because they've fallen out of bed and have hurt themselves and got a fractured neck or femur, then of course they would go to hospital. But if it's because they are slowly dying, and you're aware of that as a nursing home manager, and what we tend to do is enable people to stay at home, but make sure that the staff have the skills to manage them, and that the family members are aware and have planned out what will happen. And that's called advanced care planning. And we encourage people during the admission procedure to a care home to really think about what's their preferences. Where would they like to be cared for, both when they're admitted, and they might be quite healthy at that stage, although they might be quite frail, but looking to the future. And in the PACE Steps to Success program, we have an assessment form which is called Looking and Thinking Ahead, which you can adapt and translate, and it may be useful for you to have those conversations both with the older person but also with their family members, to start thinking about where would be the best place for them when it becomes clear that they're approaching the end of life. Yes. So hopefully that answers your question.
Yes, thank you. But the situation in Taiwan is if residents or the family members prefer the people can stay at care homes until death, the managers or care home staffs will consider and worry that care for these dying residents would increase the stress and burden of the staff in care homes. So in some circumstances, there's a demand to allocate more carers for residents during their final days of life. So I am wondering that in the UK's care homes, is it a necessary or a demand to increase the numbers of carers to look after the terminal ill patients?
Okay, you're right. Caring for somebody near the end of life requires more staff, and it requires staff who have the knowledge and skills to care for people. And that's recognised in the UK. Yeah. And some care home beds are specifically funded and allocated to provide general palliative care. So not specialist palliative care, which may be delivered in a hospice or a specialist palliative care unit in a hospital. But so there's two things. So there may be more money coming in, which allows the employment of more resources and more staff. But there will also be link workers who are typically nurses who would be perhaps able to come from the hospice to guide and improve the education and the assessment and care of older people as they approach the end of life.
Okay, it seems like external support from outside of the care homes to help or to facilitate the staff in the care home to provide general palliative care.
Yes, you're right. So there would be, it varies a little bit around the country, the whole of the UK. It's a little bit different in different places, but many care homes now have good working relationships and contacts with their nearest hospice, with their family doctor, with community nurses called district nurses, and those people would be able to go in, and mostly their role is to advise the nurses in the care home what to do, rather than to provide the hands-on care. So mostly they would help with assessing, for example, difficult symptoms like pain, or they might provide some teaching and some advice on how to improve the care of the older person who's dying.
Okay. And you have mentioned another important issue, that is fundraising to support this palliative care provision in long-term care facilities. And in the white paper, one of the macro level priorities is also mentioned that ensure funding mechanism to support palliative care provision in long-term care facility. So at most of the care homes in the UK should be seems that private facilities. So what kind of the fundraising mechanism you are using to achieve this aim in this setting, and how this fund is expanded?
Okay. Yes, you're right. In the UK, the majority of our nursing homes are in the for-profit sector. So they are commercial organisations that charge fees to older people. We have a few that are funded by the government through the local authorities. The NHS, so our National Health Service, does not provide care home facilities. That isn't what we do. Now, of course, that means that it's very expensive to go into some very high quality care homes, and people or their families need to pay additional money to do that. I think we have a mixed economy in care homes. So most people pay for their care home bed, their room in the care home, but they are still entitled to general practitioner services. So they can still see a family doctor. Now, some care homes have just one or two doctors who come in and provide care to everybody. And sometimes people stay in contact with their own doctor if they used to live in the town or place where their care home is. It differs. So the medical services that they receive are free. And if they need to go to the hospital, that's free as well. And our community nursing services are free. Our hospice services, so you mentioned that UK has a lot of hospices than we do, and they are mostly funded through charities, so people fundraise for them. So we have, so that if a nurse comes from a hospice, that's free once again for the older person. So it's a kind of complicated picture, but there is some additional resource that goes in to enabling older people who want to stay in the care home to stay there during the dying phase. And over time, over the last few years, there's been an increase in the number of people who die in nursing homes. And hopefully what we're trying to do in the PACE and other projects is to improve the quality of care there.
Mm-hmm. So it seems that the long-term care facilities in the UK or in other European countries, they have some kind of drivers or to initiate this kind of networking with the other service system in the society to to provide a better end-of-life care for their residents.
Yes, I should be careful to say that it differs in different European countries. So some European countries like Finland, care for older people in nursing homes is provided by their state taxation, their national health system. In other countries, it would be a combination of national provision and some private facilities. So the UK is a little bit different from many European countries. But going back to the white paper, what we recommend at the macro level is that governments need to think about and adequately fund some resources to enable people to have the choice to stay in the nursing home towards the end of life. And mostly that is cheaper than transferring people into acute hospitals, and probably better for their quality of life too.
Yeah, great, thank you. And besides of this lack of administrative support of palliative care in Taiwan, there's another problem is the shortage and high turnover rates of care home staffs limits their opportunity and time for educational sections. It has been another major barrier to enhance the capability of palliative care in care homes in Taiwan. So in your experience, is there a better way to implement these educational or training programs for care home staffs?
Yes, you've hit on a very big problem about staff shortages, staff lack of opportunity for education. And that's very common across many care homes in Europe, not just the UK. So it consistently comes up in the literature when we look at it. So typically in the UK, care homes are staffed by a relatively few number of qualified nurses. Mostly care assistants would be the people who provide the hands-on care. And we don't have doctors who work permanently in care homes. So it's not like the Netherlands where there is a separate specialty for care home or nursing home doctors. So how do we address that problem? So there's a number of ways to think about it. So in the PACE program, we developed a special intervention, an educational intervention for nursing home staff, both care assistants and qualified staff and other people. And we facilitated that. So we trained people in the care home, two people who were champions and could lead it on a day-to-day basis. But we also had an external person who would come in and work with the staff, because releasing people to go to lectures or meetings at a university is not practical in most of these places. And the other thing that we've increasingly done is provide some of this information online. So you're using a massive open online course, a MOOC, And I think we could do more of that. The other thing that we need to do, particularly to sustain the development, is it's really important that the nursing home manager understands the importance of education. So only when that person really recognizes and values education for their staff do I think we make good progress. So we need to make sure that we educate, first of all, the managers so they understand why it's important to improve end of life and palliative care in care homes, and then work with the staff using really practical examples, working alongside them, addressing the situation that they're in, because all care homes vary a little bit. And then helping them to feel good about each step, each improvement that they make.
Yes.
So if you have a great big change, it can feel overwhelming. But if you change one little thing, then you could build on that change and build on it until overall you've succeeded in making an important change. So I hope that would be something that is a good message to people. Work with the managers first, and then work with the teams in the care homes.
Yes. Yeah, you are right. Is this kind of practical examples that show the managers and also staff in care homes to be confident to make the progress in this kind of palliative provision. And so you have mentioned that staff and managers' attitude. So the literature suggests that the staff's worry about dealing with the death-related issues may affect their communication or their actions toward patients at the end of life. And some nurses or carers choose to work in care homes because they avoid the stress of caring for critical patients in hospitals. This kind of intervention strategy of this product is not specifically mentioned in the white paper. So from your background of health psychologist, how will you suggest for this attitude change?
Well, I think people work in care homes for a number of reasons. Partly because it's available, it may be easy for them to get a job there. And you're right, maybe they don't like the stress of working in a busy general hospital. But I think working in a nursing home is really a skilled job. People know a lot. They understand how to care for people who are very frail, perhaps have dementia. And I think we need to give more respect and value to the skills that they have. Now, typically, those people have not been trained or understand enough about normal dying, how to recognize when somebody is approaching the end of life. And I think if we can empower them so that they don't feel frightened about that kind of care, that they can start to recognize that for most people, particularly older people, the process of dying is quite calm. It's normal. They just become more sleepy, they eat less, they drink less, they gradually spend more time asleep or unconscious than awake. And if we can have good symptom control so that they're not in pain, those are the things I think we can help people understand, and then the staff become less anxious. But we have to recognize that for some nursing home staff, they are very young. People in the UK could get a job and work in a nursing home without doing a full nursing training. So they would be starting there at 18 or 19 years old. And people mostly don't die at home. So this may be the first time they've ever seen anybody who's dying. And they might be very, very afraid of that process, or afraid that they might hurt somebody or do something wrong, and the families would be cross for them. So I think as experienced staff, as managers, we could model the process of being calmly dealing and preparing people for end of life. And that means talking with the dying resident, so they're not scared. It means talking with the families so they don't have unrealistic expectations. They're not going to be resuscitated. It's not like a TV program. And if we can talk after a death, that we reflect on what went well. What did you feel went really well there? What did you think we could do that would improve the situation? And in the PACE Steps to Success program, we've called that debriefing. It's the final step. Because for every death that occurs, we can learn something new. We can reflect as a team. It's not about blaming other people. It's about all of us learning together and appreciating and valuing the skills that we bring. And that skill might be some very kind things, like bringing in some music or some flowers that the person really likes and values, so that they have it in their room near the end of life. And I think if we can help people feel less scared about dying, less anxious, particularly for night staff. I'm just very aware that at night it's not like a hospital, there aren't a lot of people around. There might be on just one or two people in the care home. So we have to build their confidence that they don't call an emergency number, get the person transferred to hospital, that they are comfortable caring and continuing to care for that person in the care home.
Yes. And you have mentioned very important that debriefing in this kind of support group is very beneficial for the staffs and the team members, that we also feel this kind of benefit in multidisciplinary team support group in the hospital or in palliative care unit. And you also mentioned that the role of advanced care planning to know the preference of residents is very important. And in the research of a PACE study, palliative care typically started within 2 weeks before death, and residents without cancer, dementia, or closely involved relatives are less likely to have palliative care, especially when the advanced care planning is lacking. So how could we help or consider this kind of palliative care for these residents whose mental capacity were not able to undergo advanced care planning communication?
Yes, it's a very difficult problem. And I always say about advanced care planning, it's always too early until it's too late. So we need to think about when are the good opportunities to do it. So one of the things we suggest is after admission to the care home, maybe not on the first day or so on, to allow person to get comfortable, to relax a little. That's the time to start, after the first week or so, to start having conversations about thinking for the future. So, and I think if we can call it something that is not too scary, not too threatening. So we hope for the best, but we always plan for the worst. So we start the process of just talking to people. what would you like to happen? Would you like to stay here? What kinds of things would make you feel very comfortable? Do you have preferred music, preferred foods, all of those kinds of things? And we can then include the family members in that, because part of the problem is often for the older person, they recognize that they may be getting towards the end of their life, but that's hard for the families to acknowledge.
Yeah.
And if you could start talking with the families to say, what are the things that are meaningful? Do they have a particular religion? Do they have some practices that you would like to happen? And in that, you can start to talk about what normal dying is, and help the person to consider the kinds of options that would be right for them.
Yeah.
And then to start to write them down. Now, the other thing is, just writing it down doesn't mean to say that should be the end. You should then revisit it. So for many people, live in care homes for many years for some of people, and you should give them an opportunity to think again, to have a further conversation, perhaps when you start to see they become more frail.
Mm.
But if you leave it right to the end, very near the end of life, which is typically what happens, everybody's stressed. The person, say with dementia, isn't able to participate anymore. The families feel very stressed because they don't understand what's happening. And they want to do everything they can to help the person who they love. So having the conversations earlier is a good idea.
Yeah.
And to recognize that all of us will die. So it's not just people with cancer. And we tend at the moment in Europe to just think about advanced care planning is for people with cancer. But people with very severe heart failure or respiratory disease, COPD, those are also people that you need to start having these conversations with.
Yes, and I like the idea that conversation in daily basis is much better rather than to complete a checklist documents of advanced directives or life-sustaining treatment decisions. Yeah, I think this kind of daily-based conversation can identify what the core value of these residents needs. Yeah.
And also within the nursing home, it's, sometimes the culture of the home where if you pretend that death never happens, then nobody can talk about it. But if you acknowledge that people do die, and I've seen in some nursing homes, they have a book, they write the names so that they can remember people,
Yes.
or they light a candle, or they have a special flower arrangement or a special place where they can go and think about the person who's died. So I think it becomes embedded within the nursing home culture that we value everybody and we value their memory too.
Yeah, and the coming question is the process of formulating the white paper mostly rely on the international experts' opinion. So the opinions of the residents and their families are few mentioned. So how do you think the patients and the public involvement PPI can benefit not only this kind of research, but also clinical practice of palliative care in care home? And how can we do this?
You've highlighted a weakness of our study. You're right. We didn't include residents, older people, and we didn't include their family carers in the preparation of this white paper. And we definitely should have done. So I think it's a weakness. In the PACE study, we did include older people. And we included the European Association for People with Dementia. So we had workshops with people with dementia and their family members. And I remember going, and we had meetings in Brussels, in Belgium, where we asked them about the process of doing the PACE study and helping us to interpret the data. So you're right. The next thing we need to do is talk to older people themselves, because their views and their preferences are really important to include in this kind of work. And in certain care homes, they already do that. They have residents groups where the manager consults with the residents and the families about the kind of policies and the changes and how to improve the life of people who live there. And I think that's a really great way forward.
Yeah, thank you. And I've recognized that the old people living in care homes have been very much affected by this COVID-19 pandemic. So what kind of lessons have been learned in the UK or in European countries about the impact of this pandemic on palliative care in care homes? And how can we overcome and to do better in the future?
Yes, in the UK, we've had some terrible experiences. In the early days of the pandemic, we had a lot of people who were residents in care homes dying. Thank goodness now they've been vaccinated. So our vaccination program started in December last year, and the biggest important priority was the older people living in care homes, and I'm really pleased. I think what we learned is how isolating it is, because people have not been allowed to visit until, in fact, yesterday, last Monday. Older people are now allowed to receive visitors, hug their family. So I think we've learned things like, one is the importance of access to personal protective equipment in care homes. One, we need to show the importance of education for staff in care homes, and that includes the end of life, so that they really understand all the procedures. And secondly, I think the other thing we really need to understand much more about is the psychological welfare of people. Some people have felt imprisoned. They haven't been able to see family, or they can only see them through a window. So we must make environments in care homes that are enriching and enabling for people. And it's been very difficult for people with dementia to understand what is happening, why they can't go out. So I think we've learned a lot. It's been a very painful and difficult lesson, but there are hope, there are things that we're learning. There's a lot of new research that is happening. Nancy Preston, my colleague, is involved in a large study on advanced care planning in care homes, and they're calling them necessary conversations. So instead of calling them advanced care planning, which most people think about as just for cancer, they're calling it necessary conversations. So these are difficult conversations, and staff need training to do them well, but they are absolutely necessary. Otherwise, we don't know what people's preferences and wishes are, and they're not prepared.
Thank you. And it seems that maybe some online resources, such as MOOC course that you have mentioned, or the telemedicine can benefit the provision of palliative care or some kind of education interventions in care home. So what is your opinion about the telemedicine of this provision?
Okay, Well, the MOOC program that I talked about before, we ran for the last 3 years, and it explained how to improve care for older people in nursing homes. We're not going to run it again, but all the materials and the resources are available free of charge on the EAPC website. So you're welcome to use them.
Yes.
You're welcome to translate them, and we'd be really interested.
Yeah.
I think telemedicine has a role. I think it's challenging because often if people need touch, they need touch to be cared for, and especially if they have dementia, it's very hard for people to articulate what their problems are or their symptoms are. So I think there's an important role for telemedicine in supporting staff. So, for example, a link using telemedicine with a specialist palliative care centre or hospice for enabling difficult symptoms to be dealt with is like a really good idea. And it uses resources wisely and economically. But I think for individual care of patients, we need to be there and really hear, listen, touch a person so that they know that they're being listened to, they know that they're being cared for. And doing that through a screen is kind of difficult for some people to understand.
I agree with your concern because I'm also thinking the same thing. And thanks for Sheila and your insightful conversation and also necessary conversation for all of us today. And we appreciate this interview very much, and also would like to invite you come to Taiwan again in the future. Yeah.
I really look forward to that, and thank you so much for allowing me to join your conference via this link. It's been a pleasure talking with you. Thank you.
Thank you. And